Hi everybody and welcome to our module on acute leukemias. Leukemias are caused by a malignant proliferation of white blood cells, and the hallmark of a leukemia is that an increased number of white cells appear in the blood. That's why it's called a leukemia. And contrast this with lymphomas, which are also malignancies of white blood cells. However, in the case of a lymphoma, the white blood cells are usually limited to the lymph nodes. So therefore the hallmark of leukemia and what makes it a leukemia and not some other disorder is the presence of an increased number of white cells in the peripheral blood. There are a number of different ways to classify leukemias, but in general they are classified by whether they are of the myeloid lineage or the lymphoid lineage. We'll talk more about this in a minute, and whether they are acute versus chronic. Acute leukemias, as the name implies, have a rapid onset of symptoms, and they involve blasts, which are very immature precursor cells in the bone marrow. Chronic leukemias have a slower onset of symptoms, or sometimes they have no symptoms at all, and the malignant cells are usually not blasts, they are more mature cells. Let's briefly review normal hematopoiesis. All white blood cells derive from a pluripotential stem cell. These stem cells can differentiate into either myeloid progenitors or lymphoid progenitors. If one of the myeloid progenitors becomes cancerous, this can lead to a myelogenous leukemia. If one of the lymphoid progenitors becomes cancerous, this can lead to a lymphoid leukemia. On the myeloid side of things, you can have a malignancy that arises from myeloblasts. This will lead to an acute myeloid leukemia, which we'll talk about in this module. You can also have a progenitor cell that becomes malignant and overproduces either red cells, granulocytes, or platelets. Those disorders are called myeloproliferative disorders. So for example, if you have a progenitor cell that overproduces red cells, that disorder is called polycythemia vera. If you have a progenitor cell that overproduces platelets, that's called essential thrombocytosis. You can also have an abnormal progenitor cell that overproduces granulocytes, and since granulocytes are white blood cells, that's called a leukemia. That's called chronic myeloid leukemia, and we'll talk about that in another module on chronic leukemias. Things are a little bit more complicated on the lymphoid side. You can have a malignancy of lymphoblasts. That leads to an acute leukemia called acute lymphoblastic leukemia, which we'll talk about in this module. You can also have a malignancy of more mature lymphocytes, and this can lead to a chronic lymphocytic leukemia, which we'll talk about in the module on chronic leukemias. And then finally, because B and T cells reside in the periphery in places like the skin and the lymph nodes, you can have a malignancy of lymphocytes in those areas, and that will lead to lymphomas, and I talk about these in the module on lymphomas. And then finally, a plasma cell can become malignant, and that leads to plasma cell disorders like multiple myeloma. So I went through the last few slides to give you a framework for thinking about white blood cell malignancies in your mind. Now let's get into specific forms of leukemia, which is the topic for this module. And we'll start by talking about ALL, which is acute lymphoblastic leukemia. And this is largely a disease of children. The peak incidence is 4 years old, and children who develop this generally present with nonspecific symptoms of not feeling well. For example, they can present with fever and fatigue. Bone pain is a common symptom. This is because the marrow is expanding and filling up with blasts. Lymphadenopathy, splenomegaly, and hepatomegaly can all potentially occur, and this is all the result of blasts being produced from the bone marrow and getting out into the peripheral blood and then filling up these organs so that they become enlarged. Some children have headache and vomiting. This is from meningeal spread of the lymphoblasts. And finally, the lymphoblasts can overtake the bone marrow and cause bone marrow depression, so children can potentially have symptoms of anemia and thrombocytopenia or neutropenia. But in general, children who develop this condition just generally don't feel well and are very fatigued and aren't themselves, and that usually leads to a blood test, and the blood test shows the presence of white cells in the periphery. In the peripheral blood, the hallmark of acute lymphoblastic leukemia is the presence of lymphoblasts. This is the picture of a blood smear showing the presence of lymphoblasts. You can see that they are large cells with a large nucleus, and they can look similar to myeloblasts, and it's important to tell the two apart in order to determine therapy. So there's special testing that's done to distinguish lymphoblasts from myeloblasts when diagnosing a leukemia. So to understand the special tests that are performed to make the diagnosis of lymphoblastic leukemia, we need to understand how lymphocytes develop, and specifically we need to understand the surface markers that are found on lymphocytes. And if you're preparing for step 1, these are the things that you want to know. The board examiners are going to expect you to recognize the markers that determine that a cell is a lymphocyte. So all lymphocytes derive from a stem cell, and then some of them will go on to become B cells, like these ones on the top of the screen, and others will go on to become T cells, like the ones on the bottom of the screen. Developing B cells have a surface marker called CD10 that will eventually go away, and then the mature B cells will have surface markers like CD19, CD20, and CD21. So the presence of CD10, 19, 20, or 21 suggests that the cell you see in a peripheral blood smear is a cell of the B cell lineage. Also important for you to know is that developing B and T cells have an enzyme called terminal deoxytransferase, or TDT. So a developing lymphocyte, whether it's a B cell or a T cell, will be positive for TDT. And if the cells you see in a peripheral blood smear are positive for TDT, it suggests that they are of the lymphocyte lineage. If we look at the blue cells on the bottom of the screen, I've shown you the surface markers that develop in T cells. Now, you're probably aware from immunology that mature T cells can be either CD4 positive or CD8 positive, and whether they are CD4 or CD8, this determines their role in the immune system. You should also be familiar with some of the other T cell markers, for example, CD5, CD7, CD2, and CD3. These are all T cell surface markers, and the presence of any of those in a cell in the peripheral blood suggests it is also a lymphocyte. This table on the screen shows a list of lymphocyte antigens, and I've separated them into those that are associated with T cells and those that are associated with B cells. And you'll notice that most of the antigens associated with T cells have lower numbers, like CD1 through CD8. And the antigens that are associated with B cells have higher numbers, like CD10, CD19, 20, 21, 22, and 23. And if you know that rule of thumb, that lower numbers go with the T cells and higher numbers go with the B cells, it can be very helpful in answering board questions, because they often want you to recognize from the surface marker whether a cell they are describing is a B cell or a T cell or just a lymphocyte in general. Now let's get back to our discussion of acute lymphoblastic leukemia. This malignancy is usually a pre-B cell malignancy. In about 70 to 80% of cases, it's a pre-B cell malignancy. We'll talk about the less common scenario where it's a T cell malignancy in a few slides. And now that you understand the lymphocyte antigens we talked about in the last two slides, it should be easy for you to appreciate that the lymphoblasts in ALL will be positive for CD10. CD10 is a pre-B cell marker. In fact, it's sometimes also called the common acute lymphoblastic leukemia antigen, or CALA, and this is because it's found on lymphoblasts in ALL. In addition to being positive for CD10, the lymphoblasts in ALL are also sometimes positive for CD19 and CD20, and that should also make sense to you because, as we just discussed, those are B cell antigens. And then finally, as I mentioned before, lymphoblasts are positive for terminal deoxytransferase, or the TDT enzyme. This enzyme is a DNA polymerase. It's found in the nucleus of blasts. It's found only in pre-B and pre-T cell blasts. It is not found in myeloblasts. So when the cells in a leukemia are positive for TDT, it means they are not myeloblasts. ALL is treated with chemotherapy, and the cure rates are generally very good. Greater than 80% of patients in most studies are able to achieve a complete remission. Now remember what I told you before, this is a disease of children, so it's very difficult for families to have a young child diagnosed with leukemia and have to go through many rounds of chemotherapy, but luckily, after going through all that, many times the child can achieve complete remission. There are two so-called sanctuary sites for this disease. These are places in the body that have poor penetration by chemotherapy drugs, and they need to be treated specially because relapse can occur in these locations. And the two sanctuary sites for ALL are the testes and the central nervous system. Special treatments like dedicated radiation or chemotherapy for these areas are often used, and this is a problem especially for boys. When the testes are treated, they sometimes become sterile later in life. There are many different chromosomal translocations that have been described in B-cell ALL, but there are two you should know about especially for step 1. The first is the Philadelphia chromosome, which is a translocation between chromosomes 9 and 22. I talk about this translocation in detail in the module on chronic leukemias, but for our purposes here, you should be aware that 20 to 30% of cases of ALL in adults carry the Philadelphia chromosome. Now, ALL is uncommon in adults. It's largely a disease of children, but when it does occur in adults, the Philadelphia chromosome is often present in the malignant cells. Only 2 to 3% of childhood ALL carries the Philadelphia chromosome. And this translocation is associated with a poor prognosis, and if you know that, it's an easy way to remember that the outcomes for treatment of ALL among adults are worse than the outcomes among children. The second chromosomal translocation is between chromosomes 12 and 21. This creates a fusion product of two genes called TEL-AML1. This fusion product impairs the differentiation of blasts and leads to the acute leukemia. Importantly, this translocation is associated with a good prognosis overall, and it's a very common rearrangement found in children, and that's an easy way to remember that the prognosis of ALL overall is good among children. You should be aware that the risk of acute lymphoblastic leukemia is significantly increased among children who have Down syndrome. The risk of ALL is 10 to 20 times higher among children with Down syndrome compared to children without, and 1 to 3% of ALL cases overall occur among children who have Down syndrome. One thing that's interesting is you may be aware that Down syndrome is caused by trisomy 21, and I just told you that there is a chromosomal translocation involving chromosome 21 that's common among children with ALL. It turns out that translocation involving chromosome 21 is less frequent among children who have Down syndrome compared to children who do not. I told you before that B-cell ALL is the much more common type of acute lymphoblastic leukemia, but now let's talk about T-cell ALL, which is the less common form of this disorder. So T-cell ALL is common in adolescent males, usually in their teens to 20s, so a much older demographic compared to the 4-year-old children who develop B-cell ALL. Also, in contrast to B-cell acute lymphoblastic leukemia, T-cell ALL usually presents as a mass. It can present as lymphadenopathy, and it classically presents as a mediastinal mass. This is a chest X-ray on the screen showing a widened mediastinum. This is the type of chest X-ray you could see in someone who has T-cell ALL. One of the reasons for the mediastinal mass and the widened mediastinum is that the thymus is usually involved, and as you know, the thymus is where T cells develop, so it makes sense that it would become enlarged and develop into a mediastinal mass in a child or a young adult who has T-cell ALL. The thymus is an anterior structure, and therefore the mediastinal masses that occur in T-cell ALL are usually anterior, and they're often associated with pleural effusions. Because the tumor can get so large in the chest, it often compresses nearby structures, and you need to know this especially for step 1. It can cause a superior vena cava syndrome where it compresses the flow of blood through the SVC. It can also cause tracheal obstruction, which could lead to difficulty breathing. Pathology specimens in T-cell ALL will show blasts. They're sometimes found in the peripheral blood, they can be found in the bone marrow, and they can be found in the mediastinal masses that occur in T-cell ALL. Importantly, however, the markers will be different from B-cell ALL. Usually the malignant cells in T-cell ALL are positive for CD7. You can also sometimes see cells that are positive for CD2, 3, 5, 4, or 8. And all of this should make sense to you based on the discussion we had a few slides ago. These are all low numbers which are typically found on T cells. Importantly, the blasts in T-cell ALL will not be CD10 positive, and that should also make sense to you because CD10 is a marker found on pre-B cells. Now let's move away from acute lymphoblastic leukemia and talk about acute myelogenous leukemia. This is an acute leukemia that develops because of a malignancy of myeloblasts. It develops from progenitors of the myeloid cell lineage. And in contrast to ALL, this disorder is more common among adults, especially males. The median age at diagnosis is about 65, and the male-to-female ratio is 5:3. Importantly, the symptoms of AML usually result from bone marrow suppression. So in ALL, we talked about how children can have symptoms from an enlarged spleen or liver or spread to the meninges. In the case of AML, the symptoms largely come because the cancer cells suppress the production from the bone marrow of other cell lines like red blood cells and platelets. So the myeloblasts accumulate in the marrow, they suppress cell growth, so therefore people will present with symptoms of anemia, for example, with fatigue and weakness and pallor, or thrombocytopenia with bleeding, especially bleeding from the gums. This is a classic presentation of someone who is thrombocytopenic. And then finally, these patients are neutropenic, so they often develop infections. The symptoms of enlarged organs, like enlarged lymph nodes, spleen, liver, these are all much less common in AML than they are in ALL. So if you understand that slide, then it's easy to understand the findings on a peripheral blood smear in a patient who has acute myelogenous leukemia. First of all, you will see relatively few red cells and platelets, and in addition, you will see the presence of blasts in the peripheral blood smear. The blasts in this leukemia are myeloblasts, so what distinguishes them from lymphoblasts? Well, first of all, you won't see any of those surface antigens we talked about for lymphoblasts, so you won't see CD10 or CD19 or CD20 in an acute myelogenous leukemia. In addition, myeloblasts have an enzyme called myeloperoxidase, and you can do a stain for this to show that the blasts seen in a leukemia contain myeloperoxidase. And then finally, another finding that's a hallmark of acute myelogenous leukemia is the presence of Auer rods in the blast cells. I've zoomed in on a myeloblast. You can see that there is this straight purple line in the cytoplasm of the blast cell. That's called an Auer rod. It's a pathognomonic finding for AML. The Auer rods are an accumulation of the enzyme myeloperoxidase, which is found in myeloblasts. And as we'll talk about in a few slides, if myeloperoxidase from the Auer rod spills into the plasma, it can potentially cause DIC. AML is classified into numerous subtypes by a World Health Organization system. The different leukemias are classified by morphology, surface markers, and genetics. You can read about these in textbooks, but the most important subtype to know about clinically is called APML. APML is acute promyelocytic leukemia, and this subtype of AML is defined by a translocation between chromosomes 15 and 17. The presence of this translocation makes a case of AML into the APML subtype. This translocation results in a fusion gene between the promyelocytic leukemia gene on chromosome 15 and the retinoic acid receptor alpha gene on chromosome 17. There are two special clinical features of acute promyelocytic leukemia that you should be familiar with. The first one results from the presence of abnormal retinoic acid receptors on the malignant cells. This is a result of that chromosomal translocation we talked about on the last slide. These abnormal receptors prevent the normal maturation of promyelocytes, and this leads to the acute leukemia. This creates an opportunity for a unique treatment that is only used in APML, that is therapy with all-trans retinoic acid, a form of vitamin A. It's interesting, this is not a chemotherapy, it's not toxic to the malignant cells. Instead, it triggers them to mature normally. As a result, the number of blasts decreases and white blood cell production by the bone marrow returns to a normal state. The second unique clinical feature of APML is a high frequency of disseminated intravascular coagulation. Promyelocytes contain lots of myeloperoxidase. Our rods are a common finding in the blast cells in patients who have APML. When myeloperoxidase is released, it can lead to DIC, and in fact this is a common initial presentation of the leukemia. Remember that these patients are often thrombocytopenic from the leukemia. If on top of that DIC begins to occur, these patients can be very sick. So the APML subtype is often suspected when patients present with blasts in the peripheral blood and evidence of DIC. It's confirmed by finding the characteristic gene translocation. I'll finish this module by discussing myelodysplasia or the myelodysplastic syndromes. These are like minor versions of acute myelogenous leukemia. Just like AML, the myelodysplastic syndromes are caused by abnormal myeloid progenitor cells. However, in this case, they don't lead to a high number of blasts in the peripheral blood, so you don't call it a leukemia. Instead, the predominant symptoms are from ineffective hematopoiesis. Hematopoiesis is suppressed by the abnormal cells in the bone marrow, and this leads to anemia, thrombocytopenia, and neutropenia. So this diagnosis is often suspected when a patient presents with signs and symptoms of pancytopenia. A bone marrow biopsy is done, and it will show dysplasia or abnormal cells, but importantly, blasts will constitute less than 20% of the cells in the bone marrow biopsy. If you find more than 20% blasts, then you call it an acute myelogenous leukemia. And as you can imagine, this can easily progress to AML if the number of blasts in the bone marrow increases. If the number of blasts become more than 20%, then you would call it AML. So really, there's a spectrum of disease from a myelodysplastic syndrome where there's pancytopenia but less than 20% of blasts in the bone marrow, all the way at the other end of the spectrum to AML where there are lots of blasts in the peripheral blood and more than 20% of cells in the bone marrow are blasts. Myelodysplasia can be a primary disorder, but you should be aware that it's often secondary to environmental factors, especially prior radiation or chemotherapy. So for example, if a patient has a cancer treated with radiation therapy, like this woman in this picture here, or if someone has a cancer treated with chemotherapy, like this woman in this picture here, what can happen is years after exposure to the radiation or chemotherapy, they can develop a myelodysplastic syndrome. And that concludes our module on acute leukemias.